Hey everybody, it's Dr. Wood and I'm doing my makeup lecture, starting off our talk on endocrinology, and we'll kind of go from there. Certainly, if any questions come up or anything, let me know, shoot me an email. It's not the ideal situation, but I do appreciate your flexibility. You didn't have much of a choice in the matter, so you'll be flexible regardless. But let's talk about our endocrinology topic here today. We'll go over diabetes as kind of being the first one that we're going to be talking about. And so to get the baseline here, we want to talk about glucose homeostasis. And it's important to know the different hormones that are going to be affecting this. We know that glucose is needed for virtually or the majority of energy supply in the body, especially for places like the brain. And you know you use glucose for a number of things like lipids and amino acids and whatnot. And so you'll find that the body can utilize alternative sources of glucose. So for instance, it can break down fatty acids and whatnot. But you'll find that there's at least a baseline minimum amount of glucose that the body needs per day in a lot of cases there. In terms of diabetes mellitus, we will consider this to be sort of a metabolic syndrome characterized by this elevated glucose. And so we know that this is a problem for a lot of patients because it does certainly contribute to things like cardiovascular disease. There's a lot of both micro and macrovascular sort of complications of diabetes. So from a microvascular standpoint, you think about things like the neuropathies that gets developed here, retinopathies, nephropathies. So we worry about things, especially with drug dosing in terms of kidney function. But certainly other things like hyperlipidemia, peripheral vascular disease, all of this can get roped in. And oftentimes patients may have pre-existing issues with some of these things and they can be exacerbated by diabetes. So looking at our guidelines in terms of diagnosis, I'm not going to get super in-depth on this because you'll get this in other classes, but typically you're looking for sort of common signs and symptoms associated with diabetes, but also the fasting blood glucose, and you may do things like glucose tolerance tests where you give the patient a large sugar bolus and then see what their blood sugars do, say at an hour and a half, 2 hours after the ingestion. And we can look at things like A1C to see kind of what their average glucose is over the course of, say, about 3 months or so. And so in terms of the different varieties of diabetes, we will talk more about things like gestational diabetes in the OB-GYN section coming up later on in the course. The most common ones you're going to run into include both type 1 and then much more commonly type 2 diabetes. With type 1, we know that they absolutely require exogenous insulin supply, mainly because they've had some sort of autoimmune condition or some condition that has led to them not being able to produce their own insulin out of their own beta cells. Whereas with type 2 diabetics, you're going to see the pathogenesis is much different. Most of the time it's related to kind of chronically high glucose levels that chronically require a lot of insulin being released that eventually leads to insulin resistance, whereas the cells don't really like to respond to insulin very well. You'll see a whole host of other metabolic complications that go along with that. And certainly you have patients who are kind of going in the wrong direction when they have impaired fasting glucose. You can see sort of delineated here about 110 to 125 milligrams per deciliter. So typically with type 1 diabetics, if they're not very well maintained, you see a lot of morbidity and mortality associated with renal failure, versus for type 2 diabetics, you typically see more of the macrovascular complications, so things like heart attacks and strokes and whatnot. In terms of risk factors, type 1 tends to be more genetically related. Maybe there's some viral causes here. Type 2 is much more based on lifestyle and based on obesity. Ethnicity can have a factor here. Certainly some genetics, but you'll find that lifestyle plays a really big role in these patients developing type 2 diabetes. So getting into the actual physiology here, you're going to see that the two most important cells we're going to be talking about include both your alpha cells, which are going to be releasing things like glucagon, and then your beta cells, which should be releasing things like your insulin. Actually, it is formed as proinsulin initially, and then actually gets broken down into regular old insulin that we're used to, which we'll talk about a little bit later on. But it's important to understand the sort of antagonistic actions that glucagon and insulin have on one another. I'm sure you know that insulin is going to drive glucose into the cells, thus lowering blood sugar, whereas glucagon does the opposite and will help to raise blood sugar by promoting things like gluconeogenesis from the liver. You can imagine here how these things change over time, whereas where you had a normal, healthy patient here, all the cells look pretty good, versus when you have a patient with type 2 diabetes, they kind of wear out those cells over time, so where they actually have dysfunction of all types of cells such that they're going to be releasing too much glucagon and they may not be releasing very much insulin. I'll show you some graphs of what that looks like as well. So you'll find the pancreas has a lot of extra residual function before patients will actually develop diabetes. So you can be on this kind of steady decline over the course of years before you'll notice the patient having impaired fasting glucose and eventually high A1Cs and high fasting glucoses. And so this is why the earlier you can kind of isolate these patients and try to intervene maybe when you're back here, the better off your patients are going to be in the long run to try to prevent those complications we mentioned. So we'll talk about type 1 diabetes first, because this is where we're going to get in mostly to talking about our different types of insulins, which are going to be pretty important for our testing purposes. You're going to see this is where we're having that loss of beta cells from the pancreas, and a lot of times it is related to an autoimmune disease, although it could be idiopathic in some cases there. I have seen that a number of patients that have an autoimmune condition that has led to diabetes can oftentimes lead to other autoimmune conditions as well, things like ulcerative colitis or Crohn's. So some of those things tend to go in pairings with one another. In terms of insulin, insulin is actually going to be a pro-hormone, or it turns into pro-insulin initially, and then in the Golgi apparatus it actually gets cleaved into insulin and then C-peptide. Insulin is going to be obviously the most important component here. Sometimes you may see people getting a C-peptide level, just to give you an idea how much insulin the patient's actually producing in and of themselves. But I'll show you a picture of what this looks like in just a moment. Basically, this is the amino acid sequence of insulin here. This is this is the whole pro-insulin sort of molecule here. And basically what's going to happen is this will get cleaved, this portion here, and then you will just have these two chains that are connected by these disulfide bonds, and that's insulin, right? This purple sort of color here is going to be the C-peptide that is not going to be all that clinically useful to us. Now, you don't have to memorize the amino acid sequence of C-peptide, but I would be recommending that you know the ones for insulin in and of itself. I'm obviously just kidding. Just want to make sure people are actually listening to this. So you don't need to know the amino acids. I will make some important points about that a little bit later on when we talk about our different types of insulin though. So as I mentioned, C-peptide doesn't really have much of a function, but can serve as sort of an index of insulin secretion. Sometimes they'll measure it to see just how much insulin should be released, because there should be a one-to-one measure between C-peptide and insulin molecules. In terms of the clearance, you're going to see the liver clear the majority of it, but you'll have a pretty decent amount going through the kidneys as well. This is important because you can have patients with renal failure who actually have a hard time clearing the insulin, and that can actually lead to things like hypoglycemia. And typically the half-life is pretty short, and you'll see with the different types of insulin we have, we can alter that pretty significantly. So how does insulin get released from the pancreas? And so this is important to know because some of our medications will play a role here. You can go back and read this, but I'm just going to show you the pictorial example of how this occurs. That makes a little bit more sense. It makes it easier for me to talk you through it. Basically what happens is that you're going to glucose coming in through these glucose transporters. We know that glucose can be broken down into shorter carbon chains that eventually can be turned into ATP, which we know to be our major energy currency of the cell. ATP is then used to close down these potassium channels here. Potassium normally is going to be flowing out of the cell along its concentration gradient, but by using ATP we can close this off, and basically the cell becomes more actually depolarizes, right? Becomes more positive, it depolarizes and causes this membrane depolarization. This will then cause these voltage-gated calcium channels to open up directly, allow calcium to flow in, and then that stimulates these vesicles filled with insulin to undergo exocytosis. You can see them being released here into the bloodstream. Okay, so this is the general model for how insulin is being released. It's in response to elevated glucose. So the more glucose coming in, the more eventual insulin you should be releasing, and that makes good sense to make sure that we can help to regulate that. If glucose levels are low, you shouldn't have a whole lot coming in here, thus less insulin being released, and you should be pretty well regulated if that is working as it should. So once insulin has been released, it's going to go to different target tissues, whether it be in the brain, whether it be in the skeletal muscle, wherever it's going. I'm not going to have you get hung up on memorizing which glucose transporters are where, but it's important to know kind of what happens once insulin interacts with these cells here. And so you can see, while it gets pretty complicated because insulin is a anabolic hormone, essentially what we want to focus on is that insulin is going to come and interact with these tyrosine kinase receptors here, which will be activated once insulin binds to it. There's going to be a lot of downstream processes that happen here, but ultimately what we care about is right here with this intracellular vesicle filled with these GLUT4 transporters. These are glucose transporters. This will stimulate, when insulin binds, it'll stimulate glucose 4 transporters to be translocated onto the cell surface, and that will then allow glucose to come in. So it makes sense. Say you eat a big sugary donut, you're going to have a lot of glucose in the blood. That's going to stimulate the pancreas to release that insulin through those voltage-gated calcium channels and whatnot. And then that insulin will then come and interact with these receptors, more glucose transporters on the cell surface, and then allows for that blood sugar to go into the cells, and thus blood sugar diminishes, right? Which makes sense. So now we have our glucose that can be utilized for energy production. We can use it for all sorts of different things. So just know that there are different types of glucose transporters. I wouldn't get too hung up on which ones are where, but they have different actions depending on where they're at, and typically different tissues may be more predominantly expressing one type of glucose transporter versus another. Getting into the physiologic effects, you can see here that many different things are going to be occurring, so it's kind of important to know what's happening where to understand a lot of the side effects and the therapeutic effects of insulin. So for instance, when the liver, when it's detecting that there's high levels of blood sugar and there's high levels of insulin, that's going to be stimulating its storage, glucose storage, as glycogen, which we know is a good energy holding on to molecule essentially, right? It's going to be a good storage molecule for our glucose. It'll also stimulate things like conversion of fatty acids and VLDL, and then eventually into adipose tissue. So this is why you see that things like carbohydrates tend to make you fat, right? Because it's not fat that makes you fat, it tends to be carbohydrates, mainly because they get stored in and put into kind of long-term storage in the adipose tissue there. You'll find that insulin is going to have an inhibitory effect on things like gluconeogenesis, which makes sense because if we have enough glucose around that we're releasing insulin, we probably don't need the liver to produce new glucose, right? And the skeletal muscle will also be storing this as glycogen. Will also be helping to get other things like amino acids into the skeletal muscle to help for, with its anabolic effects to help build up that muscle there. And then the adipose tissue, it's also going to be storing those fatty acids as triglycerides, again helping to expand and develop the adipose tissue further. So how do we release insulin throughout the day? This is important to understand when we get into how we actually dose insulin for these patients. So typically, if you're looking at insulin levels throughout the day and then you look at glucose levels, you're going to see that you have a basal amount of glucose in the bloodstream at any one time. You should, otherwise you'll have a value of 0 and you'd be dead, right? So by keeping a level, say maybe 80 to 90 or so as a basal, you'll see that this is not going to be constant throughout the day, because as you eat meals, you're going to have spikes in your blood sugar, right? Well, how do we get back down to those baseline levels of glucose? Well, we do that with insulin. So as you have a big spike in blood sugar from breakfast, you'll have a big spike of insulin at around the same time, and that will then help to get that back down to baseline, or it should, assuming you have someone with normal glucose tolerance, right? Same thing happens around lunchtime and then supper as well. So again, this is what would normally look like in terms of insulin secretion in response to glucose levels in the blood. Now, in terms of insulin formulations that we have many, about 17 different formulations, and they differ depending on things like their onset of activity, meaning how quickly they kick in, their duration of action, their solubility, and things like that. And we can even alter their pharmacokinetics pretty significantly by doing things like adding in zinc, for instance, which can help to increase the duration of action. So instead of working for, say, 4 to 6 hours, it maybe works up to 12 hours. You can do things that add protamine to get a similar effect here. So if you ever see like an NPH insulin, that does not refer to Neil Patrick Harris, it refers to NPH for protamine is there. And then we have analogs where we can actually modify the amino acid sequence and actually change that out to change the characteristics of the insulin products themselves. So to give you some examples here of different types of insulin, you can see that we have the normal sort of pro-insulin molecule here, and by changing out different ones, so for instance with insulin Lispro, we take the normal human variety of insulin minus the C-peptide, and we change out this proline and lysine for a lysine and a proline. And what that actually does is it makes it work much faster, for instance. We can do things like change out proteins 31 and 32 for 2 arginines, and that helps to extend out the duration to where it may work up to 24 hours in some cases. So just know that there's a lot of different varieties of insulin and that they're going to work very differently. And when we get into the details of them, you'll be expected to know which ones are long-acting, which ones are short-acting, etc. So how do we get insulin? Well, originally we had to go back to animal sources. We can go to other mammals and we see that there's enough cross reactivity because their amino acid sequences were quite similar, that we could use things like beef and pork products in order to replace that insulin that patients maybe were not making on their own. Now, we don't really use beef anymore, mainly because of the fact that it was pretty antigenic, which makes sense given the fact that we're injecting foreign proteins into people. And pork is still available, but it's by special order. But this is what we used back in the day. Obviously, this would be a bad thing for certain patients of certain religious persuasions, for instance, but this is not the norm anymore. Nowadays, what we can produce is actually human insulin, but it's a recombinant form. So it's not like we're taking insulin from anyone. We can actually program E. coli or yeast molecules to actually, or E. coli or yeast cells to produce actual human insulin in and of themselves with some of those modifications that we mentioned. So for instance, two of the big different brand lines that you'll see are going to be Humulin and then Novolin, and basically they're two different companies forming that. And Humulin just uses E. coli cells, and then Novolin uses Baker's yeast. So ultimately the products worked almost identically to one another. It's just a matter of how they are produced in the first place. So here's kind of the breakdown of your different types of insulin. I'll get more into the details of sort of their different kinetics. In terms of ultra short acting insulins, this is where we're going to get into our Lispro, Aspart, and then glulicine. So if you ever see insulin, Lispro, insulin, Aspart, etc., this is what this is referring to. These are the really short acting ones. They're going to be better for sort of mealtime insulin, right? So when you have a big bolus dose of glucose coming into the system, these are going to be really good to handle that. Short-acting insulin, this is our regular insulin that is, again, just the normal human variety that we produce that we can also use exogenously. So this is going to also be pretty good for mealtime insulins. And then we get into the more long-acting formulations that are going to be better for, say, 12 or 24-hour sort of coverage. So things like the intermediate NPH insulin, long-acting Ultralente, which these are still sometimes used, especially if patients have insurance issues where they cannot afford maybe a long-acting variety, but this is sort of the more common ones that I see in a lot of cases. So things like insulin glargine, Detamir, and then Degludec. There's also an inhaled variety, which is not used very commonly, but this may be preferred by patients who are somewhat needle phobic. So comparing their different actions in terms of the kinetics, we can see here that your insulin Lispro, Aspart, and glulicine are the ultra rapid acting. They have a very fast peak effect, but then they die out very quickly, meaning these are not going to be good for covering over the long term, right? Regular insulin will have a slower peak, but will provide longer coverage. For instance, you may still have some activity around 12 hours or so, but it really kind of dies off at the around 6 to 9 hour mark there. Insulin NPH is going to be better for sort of maybe twice daily dosing because you're going to get a good coverage for about 12 hours out of the day. And then we'll have our insulin Detamir and glargine, which are going to be really good for long-term coverage, say once daily dosing. We'll look at some different strategies on how we can use insulin in these patients. So how do we get insulin into our patients? Well, most of the time it's going to be by injection, usually sub-Q injection into the abdominal tissue. This is something that patients, it's a big change of lifestyle for them, and so they need to really be educated well and have a lot of buy-in. This is where your diabetes educators are absolutely invaluable for helping to get these patients set up on this, and they've done it with thousands of patients, and they are very good at what they do for the most part. We can also do things like portable pen injectors, where basically you have a pen device that is preloaded with the insulin. They just have to put a needle on the end. They'll dial in their dose of insulin, and then they can administer that sub-Q as well. With the conventional injection, they'd have to actually draw it out of a vial. What's even nicer than maybe using it for intermittent dosing, we can do continuous subcutaneous infusion. This is an insulin pump. This is actually a picture of what the first insulin pump actually looked like. Imagine carrying that thing around 24/7. Nowadays, they're almost the size of pagers or beepers. Now, I know the majority of you don't actually know what a pager or a beeper is, but it was a tiny communication device that we carry with us when we're in the hospital and you didn't get cell signals. Regardless, though, these are small devices that are actually able to give a slow, continuous infusion of insulin through a subcutaneous catheter. It's changed every few days or so. That's given as a slow, continuous infusion, and then you can actually program in bolus doses in response to mealtime glucose requirements, right? So, and this is the inhaled form, the Afrezza. This is used less commonly, but you can get some bioavailability out of using an inhaled form of insulin. So looking at this, we can see, and I don't care that you know the different options and how it comes, but some of the things I want to point out are that these are the rapid acting, so you should be able to recognize these as being the very quick acting. We know we have the regular insulin here. Now when you see this, it's important to understand when you see U100, that refers to the concentration of the insulin. You'll have basically it's 100 units per ml, and insulin's always going to be dosed in units. So it's important to understand that this is the standard concentration. All of these would be considered to be U100 varieties. They're all the same concentration of insulin. The big difference is when we get into more concentrated varieties, and we'll talk about some of the risk there in a moment. Next we have our intermediate acting insulins, and we have our long acting insulins as well. You should be able to delineate the differences in terms of their onset of action, because you need to know how to use these in a particular patient. So we also have some premixed insulins as well, where we can actually mix, say, a fast-acting plus a longer-acting insulin mixed together in order to get sort of a dual mechanism there. Maybe you could take it with breakfast and you get, say, a nice mealtime coverage along with a longer-acting insulin, to where you maybe only dose it maybe twice a day potentially. These are less commonly used in clinical practice, I will tell you. NPH is also not used too commonly, but I will say that here that the concentrated insulins are sometimes used for patients, especially with type 2 diabetes, where they are extremely insulin resistant and they require very high doses of insulin here. So here, for instance, you have regular insulin U500. So instead of the standard U100, where it's 100 units per ml, this is 500 units per ml. It's a big difference, because if you screw that up and give the wrong one, well, your patient's either going to stay hyperglycemic or they will be very hypoglycemic and at risk for things like diabetic-induced coma or seizures or death even. So you want to be really careful anytime you're messing around with different concentrations of insulin. The U100 is always going to be the standard there. And then here's the inhaled variety you can get as well. So don't memorize the exact numbers here in terms of how it's going to be working in terms of hours, but have a general idea of kind of duration of action, kind of when the peak's going to be occurring, and the duration of action. So for instance, with like the long acting, you can see here, you should be getting close to 24 hours worth of coverage here. So these would just be one-time daily insulins for the most part. You may see it Q12 hours occasionally, but for the most part, Q24. Versus something like an intermediate acting, maybe like every 12 hours. Okay, the regular and the rapid acting insulin here are both going to be used for mealtime coverage. They don't really provide long enough coverage to get, say just twice daily dosing. You're going to see there'll be some issues with that in just a few moments. So what are the complications of insulin? The number one, probably most worrisome thing and thing you want to be educating about most is going to be hypoglycemia. Again, depending on the concentration of insulin you're using, that can be a med error that can occur there. Obviously, we're very concerned about patients with hypoglycemia. We'll talk about ways to manage that in just a little bit. In terms of other problems you run into, include things like immunopathology. So for instance, you can actually develop allergies to insulin because these are proteins we're injecting there. You may find that we are developing IgG antibodies against the insulin to where it actually neutralizes it to make it less effective. And you can see some injection reactions. Normally, insulin should be kept in the fridge in order to keep it stable for longer. However, if you inject cold insulin, that can cause some injection reactions. So you do want to be watchful for that. Patients can generally just roll it in their palms, and that will warm it up to a more comfortable injection temperature. It's important that patients rotate sites around the abdomen in order not to inject at the same site every time, because that can lead to things like lipodystrophy. And then weight gain is another common thing they're going to run into. Most patients, when you find like a type 2 diabetic patient, by the time they go into insulin, they're probably going to get some weight gain out of that, which makes sense because it's shuttling all that glucose into the skeletal muscle and the adipose tissue for storage. So it makes sense that we gain weight from that. And typically for a type 1 diabetic patient who doesn't produce a lot of insulin on their own anyway, or no insulin, they're typically pretty thin. So you'd expect weight gain to occur as a result of insulin therapy, no matter which patient you're going to use it in. So there's lots of interactions that we can run into. So for instance, certain things that will decrease the hypoglycemic effect of insulin, maybe making it less effective. Maybe you'd have to give more of a dose. Again, things like corticosteroids, because we know they're glucocorticoids, they raise blood sugar. That makes sense that these would be antagonistic. Anything stimulating the liver to produce new glucose, like dobutamine or epinephrine, can also stimulate new blood sugar, which will counteract the effects of insulin. So there's a lot of interactions you want to at least be aware of. Things that can increase the hypoglycemic effects of insulin, meaning it works too well and you increase the risk for hypoglycemia, include things like anabolic steroids, because again, you're shuttling all that glucose into the cells, not only because of insulin, but also because of things like testosterone. You have things like beta blockers that actually prevent the liver from producing new glucose. A lot of different things here that can interact with it. So it's important to always check on these interactions and make sure you're looking things up, because you can always adjust the dose of insulin, but you want to make sure that you're aware of anytime you're starting something new, how you might want to adjust that dose. So when do we give insulin for patients? Typically, all newly diagnosed type 1 diabetic patients are going to start off on insulin therapy because that's what they're missing essentially. Occasionally we'll do it for pregnant women with type 2 diabetes, or if they develop gestational diabetes, because this is a very safe, non-teratogenic sort of medication for them. And then typically it's for type 2 diabetic patients who maybe are not controlled well by diet alone, or with exercise, or with oral medications. This is sort of the last stop for many of those type 2 diabetic patients. Insulin is also used as a treatment of choice for diabetic ketoacidosis. This is typically a state where you're going to see either with a new diagnosis type 1 diabetic patient, or maybe someone who's non-compliant, where they go off their insulin for a long period of time, and so your cells don't have any glucose to produce energy, so they turn to fatty acid oxidation, which can lead to acidosis and ketone production and things like that. So this is the treatment of choice for that, those patients there. We can also use it for things like HHNS, hyperglycemic, hyperosmolar, non-ketotic syndrome. This is something you see more like type 2 diabetic patients, and again, insulin is a treatment of choice there. And occasionally we use it for hyperkalemia. Insulin, along with glucose, actually helps to shuttle potassium into cells as well, and can help to lower potassium levels in the serum. So how do we dose insulin in these patients? Which ones do we give them? Well, it needs to be tailored to the individual patient's lifestyle. A general rule of thumb is going to be that the fewer injections you give may be better from a compliance standpoint, but you're going to find that you do not get as much tight control of the glycemic index, right, for those patients, or not glycemic index, but you get better, tighter glycemic control for those patients. So you're more likely to have their sugars in range more often if you're giving more injections. You have less chance of that if you're giving fewer injections, okay? Also, the more injections you're giving, you're more likely to run into hypoglycemia. If you give fewer injections, you're less likely to see hypoglycemia, but more likely to see hyperglycemia. So it kind of goes back and forth. The best way, the most tightest control you can get would be if you're using a continuous subcutaneous infusion pump, right? Because that's giving you a continuous basal amount of insulin throughout the day, and then you program in those bolus doses as need be, right? That's the tightest way to do it. But you're also going to see those are also patients that if they're not with it and they're not really in good control of their diabetes, this can also be really problematic. And we'll talk about some instances of that in a little bit, okay? Frequently, you're going to find that they'll work off of a basal bolus sort of regimen, where they're going to be getting long-acting insulins to kind of cover them throughout the day, and then bolus dosing that they'll get, say, at around mealtime. That's pretty much the most common regimen you run into. So typically you need to make sure that you're matching carbohydrate intake along with the insulin dose that they're receiving and physical activity. Obviously, if they're being physically active and they're using up glucose for energy production, they don't need as much insulin in those cases there. So they may need to actually adjust their dose down such that they don't cause hypoglycemia for those patients. And ideally, we like to give them as normal life as possible, and with as few interruptions, as few injections as need be. But again, depending on how tight of a glycemic control we want to get, we may need more of those injections. Or if we can get them a sub-Q pump, that's always going to be ideal as well if they can handle it. Ideally, the insulin administration should mimic what the pancreas is going to do. And again, one day in the future, we're probably going to have implantable artificial pancreases that are going to take care of this. But until that point, we're still having the patient monitor their glucose, usually with finger sticks. There are some sub-Q ways of monitoring this as well, which are newer, that we can actually use with like Bluetooth connections. You can look on your phone to see what your blood sugar is. But the most common way is still a finger stick and with the point-of-care blood glucose testing. And then we want to make sure that the insulin we're giving them is going to be matching sort of when their glucose is going to be high or low, such that we're going to be giving them long-acting insulins to cover them throughout the day, and then usually mealtime insulins as well to cover those big boluses of glucose. And so typically once or twice daily dosing is not going to be sufficient to get good glycemic control for these patients here. So again, refer back to this slide to see what the normal is in terms of insulin release along with glucose levels. And let's look at a few ways that our insulin regimens can be used to adjust to this, or try to mimic this as best as possible. Okay, so generally insulin doses need to change depending on the carb intake. So if they're eating a donut for breakfast, that's going to be much different insulin requirements than if they were to eat, say, bacon and eggs, based on the carbohydrate intake that they're getting there. Typically, if you're using a long-acting insulin, you want to use that in the morning and the evening if they need twice daily, or just in the morning if it's, say, just a one-time daily dose. And then basically they're going to use regular or ultra-rapid acting insulins around meal times. Now, frequently they'll use either what they call a sliding scale, where they'll actually give themselves a dose based on the preprandial glucose readings, And they'll use a correction factor to determine what their insulin sensitivity is, or basically how much glucose should change if that patient receives 1 unit of insulin. And that'll be different for every patient, depends on their glucose tolerance, and that can adjust over time as well. And also a frequent thing we'll see here being used is carbohydrate counting, where basically a patient will be able to determine how many carbohydrates they're about to ingest, and they can give themselves an insulin dose based off of that amount, right? So basically they know they're going to be eating that sugary donut, they know that they can get an approximate carbohydrate count for that, and then give themselves a corresponding insulin dose that would be more than if they're just having bacon and eggs. So here are several different sort of regimens for how you might administer insulin in order to help mimic sort of what the body naturally does. And here we're looking at normal plasma glucose concentrations. On part B here, we're going to get normal plasma insulin. So this would be, say, a normal healthy individual without diabetes. And then this is what it would look like if we, say, wanted to do, say, a 2 or 3 injection regimen. This was when there's a 2 injection regimen where we're using regular insulin along with an NPH. Remember, NPH is more the intermediate acting insulin. You can see here they'll get 2 injections, one with both regular and NPH at the morning. And you'll see here that the first dose of the regular will help out covering the breakfast time glucose increase, and then the long-acting form will help cover them throughout lunchtime. And then around supper time, they'll get another injection where the regular insulin can help deal with that, and then they'll get a second dose of NPH insulin at the same time, and that covers them throughout the night. Basically, they start all over in the morning. Here's an example where you can use a long-acting formulation, say something like an insulin glargine or Detamir or an Ultralente here, and they can get that along with regular insulin boluses as well. So they get basically 1 injection of the Ultralente in the morning, along with a regular insulin there for breakfast, so that will then cover the breakfast time. You'll see here the long-acting kind of provides nice 24-hour coverage, and then the regular will be given around lunchtime and then around supper time, right? Now the best way, the most tight control you could get would be if you're using, say, a subcutaneous pump, where basically the insulin release is going to be consistent throughout the day based on what their basal amount should be if their pancreas is normally functioning, and then they'll get little bolus doses around breakfast. And sometimes you'll see kind of like a secondary peak in glucose, and that's where the second little hump in the insulin curve is what that's for. And then there'll be another one around lunchtime, and then another one around dinner time, right? So this provides the most tight control, but again, you can imagine if something were to get screwed up and the patient were not to be very compliant, or they were not going to be sticking with it like they should, this can lead to some big issues. Not only that, but things break down sometimes, and pumps may be either not working, or maybe they're working too well and releasing too much insulin. And I've seen several kids that come into the hospital because their pump broke, maybe they're hyperglycemic, or maybe it was releasing too much and they got hypoglycemic potentially. So I'm not going to have you dose insulin specifically, but I wanted to give you an idea of how to dose insulin in these patients here. And what you're going to notice for a type 1 diabetic patient, initially, you're going to get a dose of around 0.5 to 0.6 units per kilo per day, right? Notice here for type 2 diabetic patients it's between 0.7 and 2.5 units per kilo per day. You think, well, why is the dose so different between these two? And if you had to consider, well, a type 1 diabetic patient, they don't release any insulin at all, so they don't really have a whole lot of insulin resistance versus someone who's been maybe sedentary most of their life, they have a bad eating habits and things like that. They're going to have a lot more insulin resistance, so they may require very high doses. But these are good starting points here. Typically, you're going to use 50% of that total daily dose as a long-acting insulin for the basal amount of insulin release that they should normally have, and they'll get 50% as bolus. Usually it's either regular or rapid-acting insulin, so either regular insulin or insulin aspart or glulisine. For most patients, it's going to be one of the rapid-acting because it provides nice tight control right around mealtime. But let's say, for instance, we wanted to have a 40-kilogram female who is just diagnosed with type 1 diabetes. Well, the total insulin dose for her will start in the low end. We'll say she's going to get 0.5 units per kilo per day times her weight of 40 kilograms, and you get roughly 20 units per day she's receiving. So what we're going to do is we'll do 50% as a basal, so she'll may get 5 units of insulin Detamir, which is the long-acting. She'll get that twice daily, so once in the morning, once at night. And then she'll get the rest of the 50%, the other half, as bolus dosing. And this can change based on carbohydrate intake at different meal times. So if they have a breakfast that's pretty light in carbs, you may want to shuttle these extra units over to lunch or dinner time. But let's say she gets most of her carbs at breakfast. So she can get 4 units of insulin Lispro sub-Q with breakfast, she'll get 3 units with lunch, and then 3 with dinner. And then this is just a starter dose. Once you see how they're responding to it, and they're going to keep track of their blood glucose, most of the point-of-care glucose testing will have a record-keeping feature to where you can actually go back through and see what their blood sugar is doing throughout the day, and then you adjust based off their response. And again, everyone's a little different. They're all snowflakes in a positive way, and so you're going to find that they will all require maybe a little bit different dosing adjustments based off of this. So as I mentioned, insulin pumps can provide really tight control here, but it really requires that the patient be really with it and really on top of their glucose control. If there's someone who's going to be non-compliant, someone who has frequent hospital admissions for DKA, this is not a good regimen for them, because I'd rather someone be non-compliant and be hyperglycemic than be using this kind of willy-nilly and then maybe putting themselves in trouble by getting hypoglycemic. That's much more likely to be fatal than being hyperglycemic, right? So basically, this requires them to be able to put in mealtime carbohydrates, and they can calculate a dose based off of that. So they need to really know what their insulin sensitivity is and know how to calculate their mealtime dose of insulin based off their carb intake. And so they need to really have good attention to detail, because again, this is not an actual pancreas. It won't shut off production once blood glucose gets low. It'll just keep secreting the same amount of insulin throughout the day no matter what. And so patients really require a lot of extensive training, and it's not unreasonable that pumps may malfunction, as I mentioned before. So I've seen this as a reason for hospital admissions previously. But you can find 9, 10, 11-year-olds who are like super on top of their diabetes, and they can program these pumps better than I ever could. So it's not that you have to have a patient who's, say 24 and kind of got their life together. I don't know, most 24-year-olds probably don't have their life together, but you can have relatively young patients who are very with it, because again, their minds are they're like sponges, right? They can pick up this stuff very quickly. So what do we do if patients are hypoglycemic, right? So we want to make sure that patients are educated on sort of those signs and symptoms. And you may find, especially with type 2 diabetic patients, that as they develop some of these autonomic neuropathies, they may not really be able to sense those same symptoms as they would otherwise. And again, they're going to get shaky, they're going to get sweaty, they're going to get tachycardic, they're going to get kind of hangry, right? This is what patients look like when they're hypoglycemic, and is generally when their blood sugar gets around, less than 65 to 70. The problem is people tend to overcorrect. So I don't know if you've ever been hangry before, but I certainly have, and I tend to overcorrect and eat way too much, right? That typically leads to hyperglycemia. So if the patient is awake and with it, they can do what they call the rule of 15, where basically they'll ingest 15 grams of simple carbohydrates. That can either be 8 ounces of orange juice or milk, or they may have glucose tablets they'll carry around with them. About 4 of those, and they'll consume that. They'll wait 15 minutes, they'll check their blood sugar again, and then if it's still low, then they can repeat. Okay, this is all for patients who are still awake and with it. Well, what happens if blood sugar gets too low? Well, patients can syncopize, right? Patients may start even seizing because their brain is not getting enough sugar. And so what we can do in these cases here, if they're unconscious, is either give glucagon. So most patients, especially with new diagnoses, should get a prescription for glucagon. And this will directly stimulate the liver to raise blood sugar, because it'll do what it normally does in the body and stimulate glycogenolysis and gluconeogenesis. Some other things you may find glucagon being used for is, kind of interestingly, it can cause smooth muscle relaxation in the GI tract, which is actually a big reason why it causes a lot of nausea, vomiting. But also it can be used to pass foreign bodies in the esophagus. So I've seen cases where kids will come in with a coin lodged in the esophagus, or say like a button battery or something, and if it's the middle of the night, GI doesn't want to come in, they'll say give them a dose of glucagon, and if it passes, then they're good to go, versus if it does not, then they have to come in and do a scope and get it out. But I've seen cases where they've used glucagon with some degree of success. Most of the time it doesn't work, but that's another thing you'll see it used for. If the glucagon is insufficient to get the glucose back up, or maybe the patient's been hypoglycemic for a while and their liver doesn't really have a lot of glycogen stores to work on, this is where IV dextrose is always going to be our gold standard. And there's a lot of concentrations that are available, D10, D25, D50. It's important to know that the higher concentrations tend to be rougher on the veins. So for instance, if we have like an infant who's hypoglycemic, they're going to get D10. An adult who's syncopized, we can give them D50 no problem, right? So it just depends on the age of the patient. Typically, we'll give them around 25 to 50 grams, depending on how severe the hypoglycemia is, and then we'll check them again in a few minutes, see where their blood sugar is at. Hopefully they've kind of woken back up, and then we can go from there. Again, be wary, the bigger the dose you're going to give, the bigger the concentration, the more risk for thrombophlebitis it can happen. So at this point, I'm about halfway through our endocrine topic. We'll get into type 2 diabetic patients next time that we meet. But in the meantime, if you have any questions, please feel free to let me know. I know it's a little quick, but that's why I like the in-person sessions, because we can kind of talk with one another and I can ask questions and whatnot. But if anything does come up, please let me know. And otherwise, I'll see you guys next time. Thanks a lot. Bye.